The development of this podcast was sponsored by Alexion Pharmaceuticals Incorporated. The viewpoints expressed are those of the person speaking and not of Alexion. Welcome to NMOSD Your Way Global, an educational podcast series for NMOSD patients worldwide. NMOSD stands for Neuromyelitis Optica Spectrum Disorder, a rare relapsing autoimmune disorder of the central nervous system which primarily affects the optic nerves and the spinal cord. Your podcast hosts Lalania Lloyd and Debbie Latique, who have both lived with NMOSD for over 10 years, will be bringing their respective Canadian and Australian perspectives to the table in order to help patients worldwide better understand NMOSD. Over the next 16 episodes, clinicians, researchers, and fellow patients will come together to have important conversations about how to live your best life within your diagnosis. They will be offering up encouragement and practical tips for overall health and well-being. In this episode, Lalania covers the importance of managing pain and its impact on mental health. She talks with Dr. Rajiv Reebye, a physical medicine and rehabilitation specialist at the University of British Columbia Multiple Sclerosis and Neuromyelitis Optica Clinic, and an attending physician at GF Strong Rehabilitation Center in Vancouver. Dr. Reebye explains the nuances and complexity of pain and NMO, the ways in which it affects our mental health and well-being, and how patients and their care teams can work together to manage pain and reduce its impact on our lives. So, let's get started.
So, Dr. Reebye, I'd like to begin by asking you to explain to us what a physiatrist is, because I think it's a term that not everybody's familiar with, and a lot of people confuse it with a psychiatrist, which is a completely different scope of practice.
That's a very important question, and to clarify who I am, a physiatrist, also known as a physical medicine and rehabilitation physician, is a physician, and we have 5 years of medical training, 4 years of medical school, and then 5 years of specialty training. And our mandate as physiatrists is to help optimize a patient's function through a medical model. And we are really collaborators. We really like to work with a team. We like to work with a neurologist, for example, and the allied health team, including an occupational therapist, physiotherapist, for example. We really like to empower the patient, and the patient also being the center of our focus as a team member as well. So we really like this collaborative medical approach to treating our patient.
So can you explain to us why it would be important to have a physiatrist on our care team?
I think that every patient with NMO should be seen by a physiatrist. The problem is that we don't have enough of us. I would love to have more colleagues like me to help our patients with NMO. The reason I think we should have a physiatrist on a team is because we can really look at maximizing abilities and function for every patient.
And who else do you work with to help patients?
We work with the patient. The patient is key. It's a key team member. But of course, we work closely with our neurology colleagues. I work at the UBC Multiple Sclerosis Clinic, and I have a very great relationship with my neurology colleagues and also my colleagues within the allied health field, that's including physiotherapists, occupational therapists, and nurses.
Yeah, a lot of MS clinics have sort of what I consider to be like collaborative care, where there's a variety of healthcare professionals that can help with the neurologist work with patients, social workers, neuropsychologists, PT, OT, those kinds of things. And then a lot of times nurses or nurse practitioners as well.
And, you know, I could list a long list, and I apologize. I may have missed my psychiatry colleagues and my psychologist colleagues. It's a whole team. And basically anyone involved with our patient can be part of the team, even in the community, as well as the hospital inpatient or outpatient unit.
And it's really great for patients when they're able to sort of have that one-stop shopping where, you know, you have all your care in one center so that you're not having to run around and get your healthcare sort of piecemeal. You know, it makes it much easier for us in terms of coping and being able to access care in a timely manner, I think.
I agree.
What other kinds of complementary therapies do you use with patients and why?
As a physiatrist and with our medical knowledge, we definitely want to be sure we're not missing anything medically. So working with a neurologist, for example, they refer us patients for pain, spasticity, which is tightness in the muscles, and function. So improving their abilities in grasp, for example, transfers, mobility. So exercise is another modality that we are well trained, and we can help the patient to do a home exercise program. And we can do this with a physiotherapist that can also help the patient in the community to start the exercise program. But we have knowledge of muscles, movement, tone, like tightness. So we can develop something simple for them if they come to clinic in terms of stretching program. But we also can use other modalities. For example, we are trained to think about adjunctive therapy. For example, if we do interventions for injections, we can maybe talk more about this later, but for spasticity, but we can use like TENS machine, like electrical stimulation to help pain. Mm-hmm. We can also look at the pharmacological methods, like topical creams for pain that I could prescribe or advise patients to go over the counter, or other modalities that may not be injections or medications. So we also look at a holistic model of relaxation, talking about yoga, meditation, that are very key as well in a patient's overall care.
So it sounds like you really sort of come at it from all angles to try and help the patient, that you're not just, necessarily prescribing things like medicine or exercise, that you've got sort of this well-rounded picture of all the things that could help.
Absolutely. And, our focus is a medical model for sure. But at the same time, we're looking at a practical model that we can help the patient empower themselves. So we like to motivate the patient to maximize their abilities. Even if there is a declining function, we could look at an angle as a physiatrist that we could potentially help them as a goal. And that's an important point when we looking at other strategies in our toolbox. What physiatrists like to do, very much like all of our other specialists as well, is looking at goals. We have to look at what the goals of the patient are. And then if we can help these goals, if they're realistic, we can work together towards achieving them with the patient using conservative modalities, as we've said, like stretching, exercise program. I have patients that love water, for example. So going into the pool for water, walking, if they're supervised, looking at a stretching program at home with therabands that I could teach them to distract themselves from pain. We can even have strategies that are as simple as if they enjoy virtual reality, using technology to help them with exercise if they don't like to go outside. So we can adapt a model that is unique to the patient. That's what I really love with physiatry.
Yeah, I really liked what you said about, finding out what the patient's goals are for treatment, because I think that's really key. If you're developing a treatment plan, it's really important to do it with a patient and not for or to a patient, because it will be much more successful if the patient has had a hand in, voicing what's important to them and give you an idea of what their motivation might be. So what kinds of pain issues do NMO patients typically have or experience?
It's a fascinating question, because NMO, the more we learn about the pathophysiology of pain in patients with NMO, we felt at the beginning that NMO, many patients were, as you know, diagnosed as being MS or the aggressive forms of multiple sclerosis. Now we've known that's a different entity. And it is very fascinating when you look at the scientific literature and the pathophysiology, is that the areas that modulate pain, that's why patients with NMO have a higher level of pain than patients in general compared to multiple sclerosis. So some of the research has shown up to 80% of patients with NMO will have pain.
Yeah, I remember hearing you speak at an MS event. Typical people that are healthy experience pain different than MS patients do. And MS patients experience it different from how NMO patients do. So you touched on that just a little bit, but is there a way to explain it, for a layperson that we could understand it a little bit better? Because I think a lot of us really struggle with pain.
I think if you look at it in a simple process, if you don't have MS or NMO or you don't have any neurological condition, for example, if your hand or your finger gets stuck in a door and you hurt yourself, I'm not talking a fracture, but you have a little bit of a bruise and it's really painful. You take your finger away and you go, ouch, it really hurts. After an hour or two, it dampens down if you in a normal situation, and it could last a few hours to maybe even a day or two if you don't have a fracture, maybe a little bruise there, or you can see a bit of a hematoma, like a bit of bleeding around the nail bed. Now, usually within a week, that would go away. That would go away. Now, in a normal situation, if it keeps on going beyond 3 months, we would call that chronic pain. So the definition of acute pain is any condition less than 3 months. And the types of pain could be either pain that has a feeling of electrical nature or firing or burning. And this is called neuropathic pain. And then the other definition is nociceptive pain, like tissue pain, like joint pain. But now we've noticed that the two types of pain can be married. So in a normal situation, the pain should dissipate within 3 months. So, and then it recalibrates. And then we have the brain, we have the spinal cord, these relay centers that can process and dampen down these bad pain fibers. Now, the problem is that if you have a lesion, for example, in multiple sclerosis or NMO, the wiring is not working as well. The connection and the ability to dampen down the pain is more difficult. So the pain can actually last longer. And this is what we call the nerve pain or the neuropathic pain, because it's affecting the processing centers. As I said, these areas in the gray matter in NMO or the white matter in multiple sclerosis. So it tells you like a warning sign. In a normal situation, the warning sign is to take your finger away. For example, that example when the door handle or you're off at almost like a crush, the first reaction is take away your finger, take away that stimuli. And in a few days or weeks, it should go away. And to no more than 3 months, unless you had a fracture. But in that case, I'm just giving an example of maybe a bruise to the nail bed. Now, in a patient with NMOMS, even after that bruise settles down, even after the swelling settles down, that feeling the pain may still be there even longer than someone without NMO or MS. My analogy that I give to my patients that is more simple is like a sunburn. If I had a sunburn, for example, within a few days to a week, it settles down. But sometimes that feeling of sunburn in a patient with MS or NMO, it keeps on going and it keeps being there, although the sunburn's gone. And why is that? There's a term called central sensitization where the pain fibers are upregulated. Imagine you have the bad pain fibers winning and the good pain fibers that should be dampening that or regulating the bad pain fibers are not as strong because the bad pain fibers have become stronger. And this is what happens in patients with MS and NMO or anyone having chronic pain more than 3 months. There's this kind of wiring effect that increases the pain stimuli. So just in summary, we have to look at two things. The patient is unique. Everyone's pain processing is unique. So although the studies that I quoted that patients with MS usually have less pain in proportion compared to NMO, it doesn't mean that a patient with MS has less intensity of pain compared to NMO. It just means that there may be more people with NMO that have pain at any specific time. Now, when we look at the pain in NMO and MS, they're very similar in terms of the pain patterns. They're nerve related mostly, the neuropathic pain. There's a condition, as you may know, optic neuritis. It affects the eye. This sometimes is considered one of the most painful conditions. And I also have patients who, they don't know the descriptors. When I ask them, is it burning? Is it stabbing? And they say, doctor, I don't know. These are not the words. And I'll say, well, tell me what it is. So they could be a swear word. But the classic terms for the nerve pain in NMO and MS are burning, stabbing, itchiness. Sometimes they say itchiness on the skin, or like if I put a cloth on or someone touches my hand, it's too irritating. Even wind, air going on it. It's like, my God, I have to take my hand away. So for me, these descriptors are classic, but they're not always the same. And I've had patients that come in with different types of pain. So we've talked about nerve pain, but we can also have pain from tightness. So spasticity, you may have seen patients like this or spoken to colleagues of yours. And many of my patients have this tightness of their arm or legs because of the NMO or MS. And they can have pain from that because the tightness can cause pain, almost cramping, like Charlie horse type of feeling. So this is more like a muscle crampy pain. It's another descriptor. Then you can also have different type of pain that I have patients, they walk barefoot and they say that they're walking on glass, that kind of feeling of something cutting them. Again, that nerve, but also joint pain or an inflammation pain. So this, as you can see, Lana, there's a lot of descriptors of pain. But it's so important for me when I see a patient to take a proper history, listen to their story, and also look at the uniqueness of their pain, because sometimes they don't understand, is this normal? And that's why in my clinic, I like to describe the pathophysiology of that. Means, why is this pain lasting? And it's lasting because of this wiring effect. The circuitry has gone wrong, and our body is trying to fix itself, but in a maladaptive way. And this is why patients can have long lasting pain. And sometimes we have to live with some of the pain, but my strategy is to tell them not to allow the pain to control them. So, we can talk a little bit more about that, but that's kind of a snapshot of how I look at the pain.
And I think a lot of people struggle with it. And then we go in and we're talking to whoever is trying to help us deal with it. And they show us, those, how is your pain on a scale of 1 to 10? And I've always felt myself that it's really difficult to quantify in numbers because I'm not a math person and I don't think of it that way. And when I look at that scale, I'm like, that's a scale for somebody who is healthy and has a normal pain issue. Like, I don't think that those of us who have chronic pain fit on that scale, because I always say, like, my, 6 is somebody else's 14, and because I live with it every day, my brain has normalized the level of pain that I live in all the time. And I find like it's so frustrating when somebody who doesn't know me says, what's your pain? And they're trying to gauge it. I mean, I understand there needs to be a scale, but for those of us who live with, severe chronic pain, it's kind of like, this is pretty useless to us. So I like the idea that you've said to, patients that they can express their pain in other ways that might be more relatable for them. I think that key thing is really important. And like you said, taking time to listen to their stories, because I think you get a better picture of what's really happening when you're able to do that.
I fully agree. And I come back to the uniqueness of everyone. I have to treat everyone uniquely. You can't assume that one person's NMO, even if it's the same lesion in the spinal cord, is going to react or be able to adapt to a pain pattern the same way. It's that genetics is the way that we are, our environment, our social circle. So we have to look at the uniqueness, and that's how we have to look at everyone when they come to our clinic for pain management.
Yeah. And how does pain affect our mental health?
It definitely does. It's married together, pain, mental health. If your mood is down, your pain can increase. If your pain increases, your mood can go down. So it's that marriage, and it's a chicken and the egg type of phenomenon, Lina. So usually our patients start with some pain. Let's give an example, like the optic neuritis, and it's the worst pain ever. It debilitates them. They can't go to work. They're off for a few weeks to months. They put on therapy and they improve, but then they become deconditioned because they haven't gone on their activity. If they were athletic, for example, they haven't worked. They have been isolated from their friends, the social circle. Then the mood goes down, and then they become deconditioned, and then they feel even more body pain that didn't start directly from the NMO, but it was because of this attack and this inability to actually get into their routine. So that's why it's important, even if you have an increase in your pain pattern, to keep on moving and to think about positivity. And when I'm saying moving, even if you can have someone move your limb, if you can move your limb yourself, stretching in bed. So we are very big proponents for early intervention with exercise and stretching, even during a relapse. And that's really important because that can decrease some of the pain, and that can also help your mood, because we've found that the physical aspect of pain, you can fatigue, you can get tired, you're exhausted, and then your sleep cycles change. Then it's a vicious cycle. So you can tackle every one of them. But I would say that the first thing to say is keep on being positive, even during a flare or a pain attack, because if you let that optimism down, then the system, that whole pathway of pain reduction, that processing center says, okay, the bad pain fiber is just going to overtake now. Because when you think positive, and if your mood is better, you have endorphins, and we know that these endorphins can also decrease the pain patterns. So that can regulate the pain and improve those good pain fibers. So you can see, Lina, it's kind of all connected, right? So we yes, if you do have a pain flare, your mood does go down, but we don't want it to be that when the pain reduces, then your mood is now the issue. So we have to now treat the depression and the anxiety. Right. And this is unfortunately married together. Most of my patients with chronic pain have an element of low mood.
Yeah, it's interesting. A lot of people don't realize that like depression can cause pain and pain can cause depression. So you get into this vicious cycle and you have to figure out, how do you kind of circumvent that vicious cycle?
Absolutely. And I think it's through education, Len. I feel that, the more that we work as a team with our patients, so when they come to my office, my patients are very knowledgeable. They're bringing me literature, they're bringing me all these interesting ideas because they've read it or they go on the internet. But I always tell them, you have to go to the right site. But at the same time, they do have a point that they're asking me, do I have to live with this pain? Can I cure this pain? And this is the reality that I tell patients, that beyond the 3-month mark, usually it's important that we tackle these pain issues very early. So the earlier we intervene through exercise, be it even the bed if you are not able to walk, for example, positive thinking, looking at the medication management or calling your neurologist, your physiatrist, or your team early is important, because that collaboration can help us not have as much problems in the future. The reality, though, is that if pain persists beyond 3 months and beyond, you may have to live with an element of the pain, but we don't want it to control your life, Linus. So that's is that because we can still perform our abilities, our function with pain, but we don't want it to control so that we stop doing everything.
Yeah. And in other podcasts, we've talked about like the stigma around mental health and how important it is to, share that you're having struggles with depression, because, mental health doesn't just affect your brain, it affects your whole body. And so many of us with chronic illness, and especially with NMO, because, it's a life-altering, deeply impacting disease. It's more normal than it isn't, if we can use the term normal, to have mental health challenges when you're dealing with chronic illness. And so, it's not a flaw of character, it's a flaw of chemistry. And it's also sometimes just, a thing of circumstance, So speaking up and letting your healthcare team know that you're struggling so that they can help you and try and prevent some of the fallout from not treating early and aggressively, when you're having these issues.
I fully agree.
You mentioned about pain affecting sleep, and I'm just wondering what we can do to improve our sleep if we're dealing with a lot of pain.
So sleep hygiene, having a sleep cycle is key. Even if it's changed, for example, pain has changed your sleep cycle, you should try to sleep at the same time if you can. Try to decrease your stimuli. So try not to watch TV at 11 till 2 o'clock, or binge watch 8 series of your favorite Netflix program. Also try to avoid drinking caffeine or I have patients who are still smoking, and, smoking can also be a stimulant. So for example, that's another reason to try to reduce your smoking. But meditation distraction can also help to look at sleep hygiene, taking out noise. If you have being in a quiet room, taking out anything that can be a distractor, like, for example, if you have music or your Alexa on all the time. So these environmental regulation or optimize your environment can be helpful, number one. Then diet can be also important. So not eating sugary sweets, as I said, taking stimulant drinks like coffee at night. And the third thing, there may be other reasons medically as well why your sleep has been impacted. As we said, pain could be one of them. Spasticity could be another one. There could also be other reasons, rather than saying everything is because of MS or NMO. And this is another important point that I want to say, that NMO and MS can cause many things from head to toe, as you know. Bowel bladder changes, so you could change your urinary frequency or your urgency, so waking up at night, and that could also affect your sleep. So it's important. But as I said, there may be other conditions not related to NMO/MS. So your thyroid, for example, your blood sugar should be checked because you may have diabetes, for example. So these can also affect the sleep-wake cycle indirectly in terms of temperature change and also urination as an example.
That's a prime one, because a lot of us struggle with frequency and urgency. And so, we're up and down all night long heading to the washroom. And sometimes it doesn't even matter how much we've had to drink. It just happens. And so, yeah, that's one that's really big for a lot of people.
And that's why making a schedule, maybe voiding on X amount of, this time. Also, if you have the bowel movement as well, if you can have a similar time to go to the toilet. But for the sleep hygiene as well, if it persists, then you should seek medical attention to see your family physician and neurologist for ourselves. There are also other, as I said, relaxation technique, and therapists such as occupational therapists can help as well in looking at other conservative measures without medications. There are apps, for example, now that are amazing. Some of my patients have showed this to me, that meditation and sleep apps as well. You can also have your iPhone and iWatch can also look at your time of sleep and your rhythm as well. And there may be times where you have to do some blood work to find out, are there some imbalances in the hormones in the body, for example, cortisol, that may be unrelated to the NMO and MS, but something that we could also look at, and also blood work, as I said, for thyroid and blood sugar. Then you can look at medication management or conservative management that you can speak to your physician about.
So we just have time for one more thing that I'd like to ask, and that is, what do you wish that all NMO patients knew about living with pain?
Don't let pain control you. I feel that the reality is that you may have to live with the pain. And I really feel that you have to look at like a seesaw. If you can even have a buffer, for example. So if you're 50-50, if it's a bad day and you tip down and the pain 60%, you're 40%, we should try to build that buffer. So if you can have a buffer, so you can have strategies like we've described today, distraction therapy, meditation, exercise, thinking about a different word for pain rather than saying, my God, I have pain every day. Substitute the word. Sometimes I say, patient, think about your nicest flower. So every time you talk about that pain, distract. And these are cognitive behavioral skills that you can trick your brain so that you can help dampen down those bad pain fibers. So the reality is that we may have to live with it. And if we're waiting for that solution or that time where we will have no pain, that may not happen. And life moves on and we have to adapt. And we as human beings can adapt. And with strategies that you have from your clinic and strategies from colleagues like myself and your neurologist, we can build a treatment plan that's unique to you. So I always say that we can still optimize the conservative before we optimize all the medical, but there are times we have to add the two, as you know. We have to add the medical and the conservative. But I really believe the uniqueness, it comes back to the fact that you're not the only person having the pain. Pain is something that is common for every human being, universal. There isn't a patient or a person out there who has never experienced pain. And this is one thing I tell everyone, that now with NMO and MS, the pain is a bit different because it's more nerve related and it's a bit more chronic, as we've discussed. But we can live with pain and we don't want to control, and we still can adapt. We may have to change the way that we were before these pain flares. And that's one point that I would say, is that don't consider it always a lost battle, that this is the end and this is, I can't do this and I want to give up and I'm getting depressed. We have to be optimistic and we have to allow our brain and also our system to help us in terms of infrastructure. So seek help early, number one. Number two, if you have to live with a bit of pain for a longer duration, let's learn to adapt and have techniques. And number three, understand the physiology of pain, because when you understand that, it does make sense how these medications are working, how is the conservative measures working. So that's what I'm saying. So learn about your pain and express to the physician how you really feel. And you're right, we do have these rating scales and we have these tools that we have to us, but please express yourself the way that you want to tell us, because that can give us a good understanding of how it affects us, and tell us how it really affects you early rather than waiting a year to 2 years.
Well, I really appreciate you taking this time and sharing just a wealth of information around a subject that, affects pretty much every NMO patient out there. I don't think I know anybody that hasn't struggled with pain at some point, and some of us very chronically. So I really appreciate your time and your willingness to come and share with us this important information to help empower us to react to pain in a meaningful way that's going to help us, cope better and live as healthy as possible within our diagnosis. So thank you so much, Dr. Reebye.
Thank you very much. It was a pleasure.
We hope you have enjoyed listening to this NMOSD Your Way Global podcast. For more information about NMOSD and access to support and resources, please read the podcast description. What you have heard in this podcast may not be reflective of your own experience and does not replace the advice of a healthcare professional. If you have any concerns or specific questions about NMOSD, Please speak to your physician